I begin by acknowledging the traditional owners of the land that we're meeting on today, the Yagara people and the Turrbal people, and pay my respects to elders past and present. I welcome you to this briefing, industry briefing by Queensland Health, outlining our future for technology. I want to provide a little bit of context, and some of this context Andrew has already made reference to. The Commission of Audit, which was handed down in February 2013, and it had some sweeping recommendations for government in terms of contestability of government services. Core principles that sat behind the Commission of Audit were more efficient and more effective delivery of services by government. There was an underlying principle that didn't mean government was the actual deliverer of services through its own direct labour force or its own capability. We were challenged then, we're just as challenged today, to define what contestability looks like in a wide range of services. Many of those services where there aren't competitive or viable markets in the NGO and private sector. So that really started the process of looking at what contestability means across Queensland Government. In April 2013, the government handed down its response to the Commission of Audit. And the vast majority of recommendations, I think all but 10, were adopted. There were a number there that were up for further consideration, and a very, very small number that were not taken up. And amongst those were recommendations around the contestability of ICT services across Queensland Government. Andrew's alluded to the strategy that came out of that recommendation, the Queensland Government ICT Strategy 2013 to 2017. And Queensland Health, in announcing its program of work today, really continues the journey that we've been on since April last year in terms of coming to grips with how technology can be used as an enabler of healthcare delivery in Queensland. Now we build on a number of pieces of work. We build on an assessment that's been undertaken around contestability of our services. And some of you may be aware we have been engaging with industry. We had a formal industry engagement earlier this year, looking at the first two of a number of bundles of service delivery activity. Those first two relating to telecommunications, paging and messaging, and secondly to desktop support. We're moving forward aggressively to take those to market, and that won't stop. It's central to ensuring that we deliver efficient services from our ICT platforms. But what was missing for me when I started the role in September was the long-term strategy for technology as an enabler of healthcare service delivery. Currently, healthcare delivery in Queensland consumes an ever-increasing proportion of government's revenue. In fact, if we continue growing at the rate that we have been, within 20 years there will be no funding left to deliver other services like growth in education, growth in policing, corrective services and community services. That's not an issue that's unique to Queensland. It's a national issue and one that's had significant media profile in the last couple of months since the Commonwealth budget. We now have a substantial funding gap in the tens of billions of dollars. From 2017-18 on, our funding from the Commonwealth essentially halves. And if the state government is to pick up all of that reduction in funding from the Commonwealth, we have serious challenges in this state to deliver any other services other than healthcare. Now, technology, from my perspective, is absolutely at the pointy end of ensuring that we can get our costs down, we can avoid the duplication and the waste that's occurring at the moment in the system, and that we can make the job of delivering services to our patients and ultimately improving healthcare of the wider community far more efficiently than we are today. The fact that I had to sign on Friday the second delegation, this one purchasing technology that is so outdated that one manufacturer has had to produce it specifically for Queensland Health requirement because we have a desktop that is unsupported on current technology. That cannot continue to occur. every single person in this room would be using technology at home that far surpasses what we're using within Queensland Health. That cannot continue. We take little recognition of what our employees can bring to work in terms of their technology. In fact, many of our employees would have a preference to use their technology at work instead of Queensland Health technology. Our current security arrangements prohibit that from occurring. That cannot continue to occur. So the foundation that we're announcing today and the strategy over the next 10 years is broadly described in 3 time horizons. The first couple of years focusing very strongly on building a solid foundation, and a foundation that's focused on our hospital and health services, moving away from one-size-fits-all programs of work that deliver a system-wide solution that takes 5 to 10 years, ends up taking 2 to 3 times what the original budget forecast was to deliver. That must stop. We must focus now on what our hospital and health services require, shifting the focus from central control from the department to the department being a facilitator and enabler, responding to what our hospital and health services require. And it's great to have Leslie Dwyer here today, Chief Executive of West Moreton Hospital and Health Service, and she'll be participating on the panel. And it's Leslie and her colleagues that need to define and drive how we move forward with technology, not the department. Years 2 to 5 will focus on consolidating on that foundation and focusing our systems on the patient. We deliver healthcare services in rural and remote communities alongside a number of non-government organisations. I had the opportunity a couple of weeks ago to spend some time at Wudjil. I was there on a day where one of those NGOs was seeing patients. I inquired about what services they were providing. They're actually seeing patients for the same conditions, providing the same services that we provide in that hospital. They had a completely different set of patient data files to what the hospital did. It just can't continue. We're not sharing information. We have no ability to enable NGOs to be able to access patient data on our systems and likewise to share our data with GPs. And if we're serious about getting the healthcare costs down, we must focus on integrated pathways. The community doesn't think of a GP different to a hospital, different to an allied health professional. If you have a problem, you want to go to the person who can fix it the most efficiently. You don't want to be recommended around 4 or 5 different referrals and take 3 to 4 times as long as it should be to have your condition diagnosed and treated. It's that inefficiency in the system that's driving cost up and driving it up at an unsustainable rate. Focus in the years 5 to 10 will be very much focusing away from acute care delivery to focusing on health prevention. Really taking advantage of the technology that's out there that's being rapidly adopted by the community to monitor and diagnose their own fitness, to regularly monitor their own vital signs, etc. Technology that we can't access at the moment, that we can't tap into, that we don't recognise as being clinically beneficial, and that has to change. So the 4 core elements to the strategy, or to the roadmap moving forward. Firstly, the strategy. The strategy is centred on devolved decision-making and devolved service delivery. That doesn't mean decentralised service delivery. And in a mature health system like we have in Queensland, with hospital and health services that deliver services to patients, we need to have our solutions centred around the needs of the hospital and health service. It doesn't mean that we will move in 16 different and independent directions. Quite the reverse. We expect, and we're seeing evidenced by our chief executives, a level of maturity there at being able to work together, but recognising that we need to be far more flexible and agile as a department if we're going to respond to those needs. In terms of large projects, there are no ICT projects. I will not be endorsing, supporting or continuing to fund any projects that don't have a clear and compelling business case linked to bottom line measurable benefits that have a clear business owner. And currently we're running the ruler across a large number of projects which potentially, based on the information I have, don't have a business case, don't have outcomes linked to their delivery, and don't have a clear identified business owner. And it's highly likely that those projects will cease. Doesn't mean that the activity is not required, but until we're clear on how that investment is delivering better outcomes for patients, it's money that's not there to be able to spend. In terms of operations, any services that we deliver need to be contestable. A hospital and health service has choice. From the 1st of July, many of them become the prescribed employer. They own the assets within the system. They make the decisions. The department has no patients. From the 1st of July, we have no employers other than those that work within the core department, and we own no assets. That's a complete shift in approach to the way the Department of Health services the hospital and health services. We need to be the enabler. In terms of governance and control, we will be moving to a new governance system, creating the role of Chief Health Information Officer, focused on technology and the benefits and enabling power of technology to deliver healthcare services into the future. And a second function being the Chief Technology Officer, delivering the services, the maintenance and support that exists with our legacy systems today. From your perspective, you should expect and you should demand a change in the way that we engage with you. In the past, the approach has been that we've worked internally at building up business cases, identifying our requirements, developing a market strategy, and then engaging with you at that point. And if we're serious about innovation, at that point, innovation is pretty much locked out. If it's left to us to define, prescribe, define the business case, there's very little scope for you to innovate when we come to market. That needs to shift completely. The engagement with industry needs to commence right at the start. We need to co-design with you what the problem is, co-design with you what the potential solution is, and define in specifications that come out for tender parameters that are wide, focused on outcomes, that take advantage of your ability to innovate and deliver different and novel solutions to our problems. Before I move over to the Q&A panel, I might just make one final comment in terms of the structure. I will be establishing an advisory committee made up of industry and business technology specialists to provide a high-level governance structure to support the Chief Health Information Officer. The Office of the Chief Health Information Officer will be a small, tight unit. It will have accountability for the standards, the architecture and the long-term strategy. There will be no responsibility there for delivery, maintenance, operations or support of any of that technology. The focus is very much from a business focus, so it won't be ICT-centric. It will look at what industry is doing worldwide. It will look at what consumers are doing worldwide and make recommendations to government about how we can align our service delivery to take advantage of those emerging technology trends.